Good morning. My name is Elyse Valiant with the Governor's Office of Disability Affairs. I am a light-skinned African-American woman with shoulder-length hair. Today it's brownish. If you see me, it may be black sometimes. I change up. I am wearing a red blouse with black beads, with black framed glasses, and a big smile on my face because I'm so excited that you guys have joined us for our conference. The first session of our conference will be an epic barrier removal and access to quality care anywhere. The presenters are Molly Tenen, who is the FEMA Disability Integration Specialist assigned to Louisiana. Unfortunately, Molly will not be with us today, but we do appreciate her hard work. Her co-presenter is Dr. Elyse Sparkle Stevens, who is a primary care and addiction medicine physician and assistant professor of clinical medicine with LSU. You can read the description for this session and their bios on page 1 of the conference booklet, which is linked in the chat. So thank you, Dr. Stevens, for going solo today. We know this is going to be a very informative session. And without further ado, I will turn it over to you.
Thank you so much for having me today. I'm new, so I'm as we stated, I'm with the with LSU Internal Medicine, and Molly and I met through our work with the American Red Cross after Hurricane Laura here in Louisiana. So I'm going to share my screen. I will do my best to do this justice in Molly's absence because she really she's really an amazing human being, and I appreciate and value her work so much, as do the rest of my colleagues and all of the thousands of people that she's helped here in Louisiana after Hurricane Laura, which was just devastating. So what we wanted to talk about is barriers to care and the potential of having basically a universal and remotely accessible healthcare electronic medical record. And so this is Molly. So she is in the Region 6 Disability Integration. She and I met after Hurricane Laura, where 14,000 evacuees were evacuated to the city of New Orleans in non-congregate shelters, which were actually just our fancy hotels downtown. Nevertheless, we had 14,000 additional people, many of whom were very sick, many of whom had no medicines, and many of whom did not have any of their durable medical equipment, including walkers, mobility devices, breathing devices, oxygen, etc. So we were faced with a particular we were faced with a lot of challenges, and Molly and I were able to navigate those to the best of our ability. So, and this is me. I've introduced myself and a few times, so we could skip that. So here was the problem. The problem after Hurricane Laura is that we had all of these 14,000 individuals, and we didn't know what to do with them. And this is in the COVID era, so we're very careful about our actual human contact. And there was a problem with who are these people? How can we get them hooked up with the services that they need? And how can we get them the medical attention that they need? So this brought to light a particular utility of electronic medical records, because without that, you have issues of safety, medical management, costs, access, and impact to quality of life. And we're going to talk about that in just a few cases here. So the solutions largely would be communication, right? Having the ability to talk to each other as providers, as social workers, as therapists, and have access to be looking at the same record of the patient, be able to look at the patient as a whole, know when they went to physical therapy last, what their last CAT scan looked like. And a lot of these things these are information pieces that patients are often not able to tell us. So my chart, I've been using Epics for 10 years, over 10 years. Since I was a medical student, it's been the only electronic medical record that we've ever used. So through that, I've become quite proficient. And I do have colleagues who are older than I am who have said to me, have said to students even, the electronic medical record was the worst thing to ever happen to medicine. And I want to address that because that is a lot of the pushback, is that there's a perception of the medical record being electronic, taking away from the patient interaction, where that just does not have to be the case if you're using the medical record correctly. If you are copying forward all of your notes and not doing your own assessments, of course, that's a different story. But when we use this for what it's actually intended for, we are able to put the patient in control of their own health, give them access to their notes, to their diagnoses, to their medications list, to their results. And that's possible with the MyChart app. There was also quite a bit of pushback making the notes publicly accessible to all patients. And we can address that too, because I've learned a lot from my medical career, from having to formulate my notes in a way that I feel like patients are going to understand. And I don't think that takes away from my medicine. I think it makes it stronger, because if I can't explain it to the patient, then I shouldn't be doing it. And maybe it means I don't understand it myself, right? So that's been a lot of humility and a lot of learning on my part and on my colleagues' part to figure out what is the best way to have this medical record that we're sharing now with patients. And that's been a huge, beautiful challenge that we've had. So it's amazing when patients are able to get access to the MyChart app as well. So at your fingertips, you can use it on your smartphone, you can use it on your computer, you can use it on your tablet. I have Epic on my phone. I get messages to me all day long. I get it on my tablet. I'm able to do work from home. And this has been incredibly useful during and after natural disasters when our clinic is shut down. Even after Hurricane Ida, we had a generator. I was running a clinic from my courtyard virtually and was calling pharmacies. I was able to send medicines, and none of these things would have been possible without the electronic medical record. So just I express this is the first time I'm talking to a group of people who are not in white coats for a minute, and this is really refreshing, but also like mind my medical jargon. I'm trying. Okay, so case one. So this is the case of the traveling ostomy. So these are real cases presented with permission from the patient. Some things have been altered to protect their privacy, but this particular patient was a 33-year-old female with a very complex surgical history, including resection or removal of bowel. And now she had a permanent ostomy, which is constantly draining. And an ostomy, if you're not familiar, is basically the intestine communicating directly with the outside, and it's attached to a bag. So all of your bowel movements, et cetera, are being passed through this bag. It's an incredibly uncomfortable thing for patients to deal with to begin with, can cause irritation of that skin. They require constant, supplies and cleaning and specialized care in that manner. So this is not an easy condition to live with. It also requires, in her case, frequent IV fluid infusions, because her particular ostomy was in such a place that she was constantly losing fluids like all day long. So she travels to New Orleans with the Red Cross Disaster Action Team with FEMA in response to Hurricane Laura. And she In the past, she was able to tolerate some of this movement between states without the need for medical attention. And she thought that she could maybe go a few weeks without her usual medical attention back in her home state if she was very careful with her fluid intake, which has been the case in the past, but unfortunately, this was just not the case at this time. She became severely dehydrated. She needed medical attention very badly. So this patient with complex medical history, she had no records at any healthcare facility in New Orleans or around New Orleans, and she presented to University Medical Center Primary Care, to myself, to establish care. So in a world without Epic, had I not had access to these records, I would have no idea where to start, my friends. I would have had to send her to the emergency room. She would have gotten a very expensive and extensive workup, basically starting from scratch. She would have had scans, she would have had surgical consults, and that would be extremely expensive for her and for our healthcare system, as her health insurance was based in another state. And it would have resulted in a delay in treatment and maybe inappropriate treatment if we didn't know what we were dealing with. This could have caused harm to the patient and discomfort, unnecessary suffering. And in the meantime, we would have taken her out of the field where we really needed her to be working for days to weeks of treatment and recovery, which would have impacted not only her quality of life, but the quality of life of the people that she was here to help. But because of Epic, her new PCP, which is me, was able to access all of her medical records, contact her providers back home who were familiar with her. They knew her whole story, and I was able to see their notes, watch her progress over 10 years. And this was extremely helpful for us as we figured out how to manage her care. So she was able to be rapidly connected to an infusion center without extensive workup. We had a prescription from her previous provider. The last infusion that she got, we just copy pasted. We did it again with his permission. And she was able to get the treatment immediately that she needed on an outpatient basis, and was still able to work and function and be happy, healthy, and functional. So knowing her full history, it was also clear that we could even contribute something. Back in her home state where she was in that healthcare system, she did not have access to specialists and facilities that could place a port. And a port is something that they put, it's venous access. So it attaches from the blood vessel, and it makes there's a little dot, kind of like a plastic bubble that goes kind of under the skin. And the purpose that we do this, because for patients who are getting frequent infusions, instead of sticking them multiple times in their peripheral veins, which can damage their skin, collapse veins, result in, hematomas and other things. So we place this port, and that way we can just access the same thing. We're puncturing a plastic device instead of her veins. So we were able to place that port, which was an advanced procedure that she had not been able to have. We were able to do this without complication, and she had a minimal interruption, no inpatient stay, and no delay in care. Great. Success, right? Okay, I hope that we're illustrating our point here. And I hope I'm doing justice to Molly's presentation. But case 2. So this is another patient I have. I still take care of this patient, mind you. This was from years ago, and she's still mine, and I believe she'll be mine forever. So that's the beauty of primary care, actually, is that we get to see these things longitudinally. In addition to helping people in the acute way, I can also help them as they recover from this disaster over a period of decades even. So this is a 55-year-old female with unknown medical history, and she was referred to me at University Medical Center because she needed Norcos. Chief complaint: needs Norcos. Well, Norcos, as you probably know, are controlled medications. They are opioids. We typically don't prescribe these anymore in that kind of fashion. And certainly somebody's chief complaint is never actually needs Norcos. Like, why do you need them? Why do you need this dangerous medicine? Like, what's going on? So we have no idea what's going on with this person. And I'm like summarizing how she first presented to me. So she says, Doc, I can hear her voice. Like, I'm in so much pain. I ran out of my pain meds and I can't get in touch with my doctors back in Lake Charles. Please, Doc, help me. I'm in so much pain. And I'm trying to ask her about the rest of her history. So they told me I have diabetes, but I don't really eat any cakes or sweets or anything, so I don't really believe them. So I don't take my insulin. I only take it when I feel like I need it. I don't really check my blood sugar because it hurts my finger. And Doc, I'm in so much pain. Please help me. I need Narcos. That's like at the end of every sentence. So she says, I'm supposed to take a lot of medicines for my nerves, but I don't remember what they are. Sometimes I see the ground open up and demons come out and they talk to me sometimes and try to get me to do things, but I go to church also. Where is there at church? They told me it's schizophrenia, and one time they put me away for a really long time. So we're starting to get a little bit more involved, right, than needs Norcos. So she says, oh yeah, they said I had cancer that one time, but I think it's gone. They did surgery and I got chemotherapy and radiation, and I think I finished the treatment, but I don't remember. I don't like medicine. It made me tired. Then I got these stupid breast implants, but somehow they burst and it hurts real bad, Doc. I just need my pain meds and I'll be okay. Oh, and my arm, I don't know why it's been like that for a while. I don't remember when it started. I don't know why it's so much bigger than my right arm, but I just need my pain medicine and then I'm good. So in a world without Epic, this is a giant question mark. I am seeing this patient, she's giving me this kind of story, and I'm trying to piece together. I can guess at certain things, and there are a lot of things about her that I'm really concerned about. I am concerned that she probably needs her Norcos. If she's been taking them for 20 years, she's probably going to withdraw if she doesn't have them. But I'm also kind of concerned about the ground opening up, and I'm definitely concerned about her diabetes, her questionable history of cancer, why her left arm is 6 times bigger than the right arm, and what's going on with those breast implants. How can I help? I'm so confused. So there's no way to know if I can possibly prescribe these controlled substances. If I don't know her, I don't know where she came from. There's no way to know about her organ function without doing all these tests all over again. And there's no way to know if this swollen arm is a medical emergency or if this is chronic. She is not able to give me those story points. And a lot of that brings up some good points about vulnerable patient populations, mental health, and barriers to care, even back where she was in Lake Charles. So all of these things could lead to potentially contraindicated treatments. If I give her medicines that she's not able to process because of possible kidney failure, which can happen with diabetes, liver failure, or what have you, I could kill her. And there would also be a significant delay in care while I try to figure all this out. This would lead to inevitably patient suffering, risk of acute crisis, risk of medical emergencies, psychiatric emergencies. Where in the world do we even start? So I do want to just briefly touch on the social determinants of health and why having this access to her medical record was so pivotal in helping her and other patients in her position. Vulnerable patient populations, primarily elderly patients with little health literacy, which can happen with lower education, socioeconomic status, and chronic diseases. And Lake Charles, to begin with, was a very underserved area. So a lot of patients, even if they were seeing doctors, had very minimal care for their chronic conditions for a lot of reasons. And this woman clearly had some problems with mental illness, and this can get in the way of just everything. And so being able to help her meant that I had to know more than she knew. And Epic was just instrumental in doing this. So because of Epic, I learned that she was a 55-year-old female, indeed, had aggressive breast cancer treated with surgery. She did not complete the chemotherapy or radiation. She, because she stated she didn't like the medicines. The other pieces kind of come together. So I'm listening to the patient, but I'm also looking at her history. She did have ruptured breast implants, which resulted in disfiguration and, yes, very severe pain. These have been going on for years, and that is why she's on these Norcos. So she also had debilitating and painful lymphedema, just chronic swelling of that left arm, because the ruptured implant had blocked the lymph flow from that arm. And it was just chronically swollen, tight, very uncomfortable, and yes, very painful. So I also learned that she had wildly uncontrolled diabetes, and schizophrenia completely untreated. And she was chemically dependent on opioid pain medication. And so it made sense that she's in pain right now. She's currently about to go through withdrawals. So because I was able to get all of this information about her, multiple medical emergencies were averted. I was able to start insulin immediately. I was able to expedite a psychiatric evaluation. I was able to connect her with our cancer center, connect her with breast surgery at UMC. I also, yes, did refill her Norcos. So I did want to talk about also just briefly, this is a poster presentation that one of my brilliant medical students presented at the Institute for Street Medicine Symposium back this September. And we talked about opioid use disorder, which is chemical dependence on opioids, whether that's prescription or heroin or fentanyl. And it becomes a disorder when there's a dysfunctional pattern of behavior regarding getting access to those opioids, really taking more than you need, possibly overdosing, and having a lot of increased risk for other health outcomes. So that's a huge problem in New Orleans, as it is, I think, in the rest of the country. And we're seeing rapid increases in overdoses since the COVID era and since the rise of fentanyl. So Aniko did this project about patients after Hurricane Ida and what happened to them when they lost contact with their providers and they were unable to get their medicines for their opioid use disorder, which was previously was in remission. And a lot of patients did very poorly, but the patients who did very well were the patients who were able to get access to their providers via telephone, and those providers were able to take care of them remotely. Myself, I was able to take care of a lot of patients remotely, even if I had never seen them before, because I was able to look at their electronic medical records and see that, yes, they were on this medicine for a long time and they're going to withdraw and probably relapse if they don't have it. So because of that, I was able to be kind of a temporary provider for a lot of patients who were displaced after Hurricane Ida. So there is, this is some information about how to sign up, and I'm sure we'll share this with y'all if you would like it. So anybody with who has in health systems that use Epic, you can access My Chart very easily. And there's also access to a nurse hotline where you can get emergency or urgent advice from a nurse. They can connect you to a physician. And a lot of times that's me if it's during a hurricane and I'm the only one answering. But any physicians really can get access to this as well. So they can help their patients and even the patients of other physicians. You can also do this across states. So that's why I was able to get access to our ostomy friend's medical records, because she was in fact from out of state. And this is so helpful when patients are displaced from natural disasters and when they move in general. You can sign up all by yourself. You don't need anyone's help. And so I appreciate your time, everyone. Thank you for listening to me. And I wanted to also say thank you to FEMA for delivering me, actually, my husband, who came with FEMA with EMS during Hurricane Laura when I was working with the Red Cross, and that is actually how we met. And so we've been together ever since. So special thank you to FEMA for that and for helping our community in so many ways over the past years.
Thank you, Dr. Stevens. We have a few Q&A. Would you mind taking those?
Sure.
Okay, Elyse, do you want to read those?
Sure, yes. And thank you, Dr. Stevens. I think the most important thing your patients had, along with the data and information you were able to get on them, was a caring and empathetic and knowledgeable doctor. You're awesome. So this is from Christy Curtis. Please address linking of the different networks on the MyChart app and how to set up each provider network. My son is currently a patron for networks here in South Louisiana. Example, Ochsner's, OLOL, ICMC, etc.
Yes. Okay. This is my favorite thing, y'all, because so Ochsner uses Epic, LCMC uses Epic, and the MyChart app for on the patient side is one app. And you just sign up for the various institutions and you have access to all of those records through that one app. And I also have access to all of those records through Care Everywhere, which is a little link on the side of the Epic on the provider side. So I can see all of those. Actually, the only records in South Louisiana that I'm unable to see are Tulane's records, and that is also about to change since LCMC is absorbing Tulane. So it's something that everybody is kind of rapidly acquiring. And I will also say that FQHCs, like federally qualified health centers, can also get access to Epic. So I work at several other facilities. I work at Grace House, Bridge House, which is a rehabilitation center for patients with substance use disorder. I also work at Ozanam Inn, which is a shelter for unhoused individuals. I also work in various street clinics. And through this, I'm able to get access to Epic as well and place notes in the chart as off-site clinic visits. So everyone back in the hospital is able to see what I'm doing out on the street.
Okay, interesting, thank you. An anonymous attendee, I think that the usefulness of electronic medical records speak for themselves, but are an overwhelming prospect for most people for numerous reasons. Internet devices and unfamiliarity with accessing documents online. Did you want to?
Yes. Yeah, overwhelmingly, I think like for on the patient side, I'm assuming that, yeah, this is a barrier. Yeah, for sure. And that is one that we are, as a on the healthcare side, what we can do is help patients when they come to clinic, try and see if we can get it like in real time on their phones. But yes, a lot of patients just don't have the technical insight or ability to do that. So nevertheless, though, a lot of the utility, as you mentioned, is on the provider side, and we're able to help the patient like that. Definitely a barrier to care for sure.
Okay, here's another one. Outside of big hospitals / healthcare systems, is the usage and implementation of EHR / Epic fairly common? If not, how do we encourage our healthcare providers to get on board? As someone with a complex healthcare condition, Epic has been instrumental / game-changing in keeping in line with my own health during natural disasters and everyday life.
Yeah, absolutely. Yes. So great point. And yes. So Epic also, so while Epic is like $1 million bajillion software for healthcare industries, they also have something called Epic CareLink, which is a free version basically for nonprofits, for FQHCs, for organizations that qualify, that are providing healthcare for patients like myself when I'm out providing healthcare with in the camps, for unhoused patients. Like I'm also able to get that through Epic CareLink. So they do have that option, and we can certainly send out links on how to get that if you have an organization that's interested in applying.
Okay, from
I don't work for Epic, by the way, so I'm just a fan.
From James Mitchell. Urban search and rescue encounters these people in the field, especially early in a response. Is there a way to link this information to urban search and rescue in the field?
I would imagine yes. And I would imagine that you could have the organization apply for Epic CareLink. I think that because that's a free version and it's definitely available in the field on any cell phone or wireless device. So I would imagine that yes, if the organization were to apply for that, then that access could be super useful. Yes.
And from Alexis Anderson, do jail healthcare providers have access?
So technically no, but a lot of the jail providers also sometimes provide services at the hospital. So they may have, kind of dual appointments. So they may, kind of be able to look stuff up on, on the side as a LCMC provider or Ochsner provider on the side, but that's not, but it's definitely not regulation. Jail also, along with Tulane is one of those like black boxes. They're a fortress. We can't see what they do, and I imagine that they usually can't see what we do. That's a huge barrier to care, and something I've definitely fought many battles on is trying to make sure that our patients who are incarcerated also get the care that they need. We're working on it.
From Jonathan Landry, is there a way to link Epic to other systems? I think link Epic to other systems. We use Therap, THERAP, which is a IDF/IID software.
So I don't know, but I do know that Epic does have integration links like to informational sources like UpToDate, Visual DX. So they are able to integrate like other systems, but that would be in the, definitely in the paid version, which would be like in the main hospital systems. But I know I can't speak specifically to what that is, but I do know that they do link pretty well with other systems, and it's a really I think the goal of Epic really is universal healthcare records, and to my knowledge they haven't put up any barriers to linkage with them really for anyone.
Okay, thank you,
I don't
Dr.
work for Epic,
Stevens.
guys.
Any
I was
other-
raised with Epic.
You were what? What'd you say, Dr. Stevens?
Well, thank you all so much for having me on this beautiful. Thank you all so much for having this beautiful Monday morning. And I appreciate, my internet connection is somehow unstable. Okay, thank you for having me on this beautiful Monday morning. I really appreciate everybody's time. Please let me know if you have any questions. And in the future, I'm happy to work with any of y'all in times of disaster, which are impending, I'm sure. So I'll be here.
Thank you,
Dr.
Dr. Stevens. Oh, Bambi has a question. Go ahead, Bambi.
I don't have a question, but I just wanted to let you know I received an email from one of our active members with our office, and she said, Dr. Stevens is amazing. She is my primary care physician. She is very relatable and most of all caring. It was her thoughtfulness that caught my cancer early. She did not dismiss anything. She is an A+ physician.
Oh, thank you. I have the best job in the world, honestly, and I never have a bad day. I have the best patients. Like, I get to do this all the time, guys. I really, I don't know a lot of people that can say that about their job, but I genuinely love doing what I do, and I'm so happy to have all of these opportunities. Thank you.
And there's people asking for your contact information. So is it okay if Bambi shares that?
Absolutely. Absolutely. I mean, and I have armies of medical students, y'all. So if there's a project, if there's a thing we need to do, we're ready to do it. Please let me know how we can help with any of your efforts.
Well, Dr. Stevens, we really want to thank you. And this was an excellent way to start off our conference. And you at the last minute going solo. We appreciate you and Miley's work. It was a great presentation, great way to start everything off, very informative. Our next session, are there any other questions? Because we do have a few more minutes if anybody want to quickly jot a question in. Okay, well, thanks again. You and Molly, excellent presentation. And just thanks for all the work that it's obvious that you're doing. And thanks for being compassionate. My husband had sickle cell, so we were constantly dealing with people in the medical profession. And boy, to run into someone as compassionate and empathetic and knowledgeable as you are is excellent and such a great way to start off our conference. Our next session, thank you, will begin at 10:15. You are welcome to remain logged on during the break. Thank you, everyone, and thank you again, Dr. Stevens.